Welcome to our comprehensive overview of epidural scarring associated with spinal cord stimulation (SCS) electrode placement. In this video, we'll explore a series of case reports that highlight the clinical presentations, imaging findings, surgical interventions, and outcomes related to this rare but significant complication. Epidural scarring can lead to a variety of neurological deficits and pain syndromes, making it crucial for clinicians and patients to understand the potential risks and management strategies. Let's begin by setting the stage with a brief explanation of what epidural scarring is and why it matters in the context of SCS procedures. Spinal cord stimulation is a widely used technique for managing chronic pain, especially in conditions like complex regional pain syndrome (CRPS) and persistent spinal pain syndrome (PSPS). The procedure involves implanting electrodes near the spinal cord to deliver electrical impulses, which can help modulate pain signals. While generally safe, SCS can sometimes lead to complications, including the formation of epidural scar tissue. This scarring can compress neural structures, resulting in new or worsening neurological symptoms. Now let's delve into the clinical symptoms that may arise due to epidural scarring after SCS electrode placement. Patients with epidural scarring often present with a range of neurological symptoms. These can include arm or leg weakness, aggravation of pain, burning sensations, clonus, increased tendon reflexes, and sensory disturbances such as numbness or dysesthesia. The latency between SCS electrode placement and symptom onset varies, sometimes occurring months or even years after the initial procedure. Recognizing these symptoms early is vital for timely intervention and improved patient outcomes. Next, we'll look at the imaging techniques used to diagnose epidural scarring. Diagnosing epidural scarring relies heavily on imaging studies. Magnetic resonance imaging (MRI) is the gold standard, providing detailed views of soft tissue changes and scar formation around the spinal cord and electrodes. Computed tomography (CT), sometimes combined with myelography, can also be used to assess bony structures and the extent of fibrosis. Plain X-rays may help in evaluating electrode position, but are less useful for soft tissue assessment. Accurate imaging is essential for planning surgical interventions and monitoring postoperative progress. Let's move on to the types of surgical operations performed in these cases. When epidural scarring leads to significant neurological deficits or pain, surgical intervention may be necessary. The most common procedures include removal of the electrode, excision of the scar tissue, and sometimes additional spinal surgeries such as laminectomy or laminoplasty. In some cases, instrumentation or fixation is required to stabilize the spine after scar removal. The choice of operation depends on the severity of symptoms, the location of the scar, and the patient's overall health. Next, we'll examine the pathological findings from these surgical cases. Pathological analysis of excised scar tissue provides valuable insights into the underlying processes. Common findings include dense fibrous tissue, chronic inflammatory reactions, foreign body giant cell responses, and granuloma formation. Some cases show fibrosis without significant inflammation, while others reveal acute and chronic inflammatory changes. These findings help differentiate between simple fibrosis and more complex reactions, such as those involving foreign materials or latent infections. Understanding the pathology guides future management and prevention strategies. Now let's review some representative case reports. One notable case involved a patient who developed quadriparesis following SCS electrode placement. The patient experienced arm weakness, increased pain, and burning sensations in the upper extremities. Imaging revealed significant epidural scarring compressing the spinal cord. Surgical removal of the electrode and scar tissue led to gradual improvement, with the patient eventually regaining full neurological function. This case underscores the importance of early recognition and intervention in preventing permanent deficits. Another patient presented with persistent pain and weakness in the lower extremities after SCS electrode implantation. Despite initial improvement, symptoms recurred several years later. Imaging and surgical exploration confirmed extensive epidural fibrosis. Removal of the electrode and scar tissue provided partial relief, but some neurological deficits persisted. This case highlights the potential for delayed complications and the need for long-term follow-up in SCS patients. Some cases, pathological examination revealed granulomatous inflammation with foreign body giant cell reactions. One patient developed worsening neurological symptoms years after SCS electrode placement. Surgery uncovered dense fibrous tissue with granulomas and multinucleated giant cells, likely in response to electrode materials. Removal of the affected tissue and hardware resulted in significant symptom improvement. This case demonstrates the body's potential to mount a chronic inflammatory response to implanted devices. Some patients experience a gradual loss of SCS efficacy due to scar tissue formation. For example, a patient with CRPS initially benefited from SCS but developed increased pain and neurological deficits after several years. Imaging showed extensive epidural fibrosis around the electrode. Surgical intervention, including electrode and scar removal, restored some function and reduced pain. This case illustrates the dynamic nature of SCS outcomes and the impact of scar tissue on long-term effectiveness. In complex cases, patients may require multiple surgical revisions. One individual underwent several operations due to recurrent epidural scarring and electrode malfunction. Each surgery involved removal of scar tissue and repositioning or replacement of the electrode. Despite these efforts, the patient continued to experience neurological symptoms, emphasizing the challenges in managing recurrent epidural fibrosis. This case highlights the importance of careful surgical planning and patient counseling. Severe complication reported was complete paraplegia with bowel and bladder incontinence following SCS electrode placement. Imaging revealed a solid fibrotic mass compressing the spinal cord. Surgical removal of the electrode and scar tissue was performed, but neurological recovery was incomplete. This case serves as a reminder of the potential risks associated with SCS and the need for prompt intervention when severe deficits occur. Not all outcomes are negative. In several cases, patients achieved full recovery after timely surgical intervention. For instance, a patient with worsening pain and neurological deficits underwent electrode and scar removal, resulting in complete resolution of symptoms. Follow-up imaging confirmed the absence of residual fibrosis. This case demonstrates the potential for excellent outcomes when epidural scarring is identified and treated early. Pathological reports described chronic inflammatory reactions without specific infection. Patients presented with pain, weakness, and sensory changes. Surgical removal of the electrode and scar tissue led to gradual improvement in most cases. Pathology showed fibrosis with chronic inflammation but no acute infection, suggesting a non-infectious immune-mediated process. These findings inform future approaches to device selection and surgical technique. Rare instances, patients develop foreign body reactions to electrode materials, leading to granuloma and osteolysis. One patient experienced worsening neurological symptoms years after SCS, with imaging revealing bone loss and granuloma formation. Surgical removal of the electrode and affected tissue was necessary. This case highlights the importance of monitoring for late-onset complications and considering material biocompatibility in device design. Notably, some patients experienced immediate pain relief and neurological improvement following surgical intervention. For example, a patient with severe pain and paresthesia underwent electrode and scar removal, resulting in rapid symptom resolution. Pathology revealed fibrosis with granulomatous tissue formation. This case illustrates the potential for dramatic improvement when the underlying cause is addressed promptly. In other cases, recovery was slow and progressive. Patients with long-standing fibrosis and neurological deficits required extended rehabilitation after surgery. While some achieved full recovery, others continued to experience mild residual symptoms, such as limb weakness or sensory changes. These cases emphasize the variability in outcomes and the importance of individualized patient care. Pain recurrence is a common challenge in patients with epidural scarring. Even after successful surgery, some individuals experience a return of symptoms months or years later. This may be due to new scar formation or incomplete removal of fibrotic tissue. Ongoing monitoring and, in some cases, repeat interventions are necessary to maintain symptom control and quality of life. Elderly patients with SCS electrodes are also at risk for epidural scarring and its complications. In one report, an 85-year-old woman developed increased dorsal and lumbar pain, general hyposthenia, and lower limb paresis. Surgical intervention provided some relief, but age and comorbidities influenced recovery. This case highlights the need for careful patient selection and tailored management in older adults. Patients with underlying neurological conditions such as multiple sclerosis, MS, may face unique challenges after SCS electrode placement. One MS patient developed fibrosis and granulomatous inflammation resulting in pain and neurological symptoms. Surgical removal of the electrode and scar tissue led to improvement, but the underlying disease complicated recovery. This case underscores the complexity of managing SCS complications in patients with pre-existing neurological disorders. Summary: epidural scarring after SCS electrode placement is a rare but serious complication that can lead to significant neurological deficits and pain. Early recognition, appropriate imaging, and timely surgical intervention are critical for optimal outcomes. Pathological examination provides insights into the underlying mechanisms, guiding future prevention and management strategies. Each case highlights the importance of individualized care and long-term follow-up. Thank you for joining us as we explored these important case reports and the lessons they offer for clinicians and patients alike.